Okay? Normal alveolar ventilation is 4 to 5. Okay. To control your CO2, it's either that you are adjusting your tidal volume, or you are decreasing or increasing dead space, or you are increasing or decreasing respiratory rate. Okay? So that's the formula for alveolar ventilation. If I want to blow off more CO2, I'm going to increase the tidal volume, or decrease dead space, or increase respiratory rate. That increases my alveolar ventilation. Okay? If I want to decrease it, I decrease my tidal volume, I increase my dead space, or decrease my respiratory rate. So 3 ways to do respiratory alkalosis or respiratory acidosis. But the question is usually, which one would you do first? Okay? All right, let's keep on going here. Adequate alveolar ventilation results in respiratory, inadequate alveolar ventilation results in respiratory acidosis. Okay? Excessive alveolar ventilation results in respiratory alkalosis. So we went through our dead space here. I'm not going to go through it again. We have anatomic dead space, which is the air that is here when you breathe in. Okay, it's based on your ideal body weight. Okay, your height, how tall you are. Okay, anytime you intubate somebody, you decrease dead space. Okay, intubation is the only thing that can decrease your anatomic dead space. And then we have the alveolar dead space, the amount of air that fills area of the alveolus that is not being perfused. So it's like this. So you have your pulmonary capillaries. Okay, so you have a clot here. So as a result of that, this area is not being perfused, but the air is still coming down. So this here will be your alveolar dead space. Okay? Alveolar dead space is not much. It's very small in value. It is insignificant. We really don't count it unless you have a dead space disease on board. Like if you have pulmonary embolism, that's a dead space disease that will increase your alveolar dead space. Okay? If you have CHF, if you have pulmonary hypertension, all of those things will increase alveolar dead space. Otherwise, we don't count it. Very small. Physiologic dead space is the sum of the alveolar dead space and the anatomic dead space. The sum. Okay, and then mechanical dead space is the amount of volume that is between the ventilator Y and the patient. Right here. Anything here. Your HME, your ballot, your capnography sensor, those 3 things usually connect here, and then we'll hold up some volume. Okay? When the patient exhales out, the air goes out, but you still have some air in there, which is how your CO2. Patient breathes in again, the ventilator cycles back on, you will push down this air down first, this air here down first, before the fresh air begins to enter the lungs. That is called volume rebreathe. That's another name for dead space. Volume rebreathe. You are rebreathing CO2, and that will cause your arterial CO2 to rise. Okay? So anytime dead space goes up, CO2 goes up. Okay? Normal mechanical dead space is 150 milliliter or less. 150 milliliter or less. Now, in fixing acidosis, the very first thing that you look for is dead space, see if they have dead space. You don't have to wait until it's 150, greater than 150. If it's 1 or 5 or 6, as long as the patient is acidotic, That's what you're going to remove first. You don't have to wait until it's above 150. But what we're saying is that if you have dead space in the amount of 150 or less, it will not significantly increase your CO2. It doesn't mean that it doesn't increase it. You're still rebreathing CO2. But that amount of rebreathing will not cause it to rise so much. Okay? But if you have somebody that is acidotic, remove any dead space that they have. Any questions about that? Here is the formula here. Okay? Paco minus Pico over Paco. Okay? It says a patient has CO2 of 40 and excess CO2 of 30. What is the VD-VT ratio? For information, VD-VT ratio, now VD does not stand for venereal disease. It's not what it stands for. And then the VT does not mean Valentine's Day. So don't be confused about that, okay? So VD-VT ratio means how much of tidal volume that you inspired is up here, dead space. That's what it means. What percentage of the tidal volume? Okay. We're gonna work this out. I have it on the other slide. And then this one here says a patient has a dead space volume of 250 milliliter and a tidal volume of 500. What is the patient's dead space? Now, I used to have a student, or I had a student in South Carolina, and I was going over this, and I said, wow, Sharon, do you remember what I told you yesterday about the VD-VT ratio? She said, yeah. I thought, oh, yeah. VD means Valentine's Day, and VT means Valentine's time. I said, well, what is it equal to? And then she said, well, it's equal to baby. I'm like, no, you got it wrong. Valentine's Day over Valentine's time equals baby. Can you imagine that? All right, so here's number one here. 40 minus 30 divided by 40. The answer is 25%. What does that mean? It means that 25% of that tidal volume is up here. Okay? That's your VD-VT ratio. So, because on the exam, they can say, well, calculate the VD-VT ratio. You stop right here. And again, they may say, well, the patient has a chair tidal volume of 600 on the ventilator. What is their dead space volume? That's different. You're going to take that VD-VT ratio, multiply it by your excess tidal volume to get the tidal volume that is up here that did not go down into the alveolus. Okay? All right, so here's that number 2, okay, where we were given the dead space volume and the tidal volume. So just plug it in like it says. Dead space divided by tidal volume equals 50%. So that means that 50% of your tidal volume, which is 500, is up here. What's 50% of 500? That's 250. 250. 250 went down into the alveolus. 250 did not go in. That's abnormal dead space. Normal dead space is 25%, or some books say 20 to 40%. Okay, so if you can get like 60% of your volume inside your alveolus, that would be good. Causes of respiratory acidosis. Pulmonary edema and pneumonia. Yeah, you got a lot of fluid inside the alveolus. That decreases compliance. Your lungs cannot distend. You can't get enough tidal volume, therefore your CO2 is going to rise. Pleural abnormalities, yes. Right here. Anytime you have something inside the pleural space, that will prevent the lung from expanding. Here's your pleural cavity here. The normal pressure there is -5. That's normal pore pressure. Now, if I have air coming in here from the lungs, one lung interrupted, air is coming in here, the pressure goes up. It becomes less negative. So what you get there is, you have this pressure now going this way, and here is a lung unit here that is trying to expand that way. Well, it can't. It can't expand because there is an opposing pressure there. You have pleural effusion, fluid in here. The same thing. That will cause the pressure to rise. You have lymph in there. That will cause it. You have blood in there. That's hemothorax. That will compress your lungs. So if your lungs can't do this, then you're not going to let them, your CO2 is going to rise. There's a procedure called thoracentesis. Thoracentesis is where the doctor, if you have fluid in here, the doctor is going to poke a needle in there and draw out some of the fluid. Make your pressure go back down to -5, and your lungs will now re-expand. If it is air, that's why we put in chest tube, to evacuate the air. Okay? Chest wall abnormalities, yes. Look, for your lungs to be compliant, your chest wall has got to be compliant as well. Like if I'm doing this and trying to breathe, well, they have nowhere to go. If you have trauma here, which caused flared chest, well, your lungs can't expand. So that may cause respiratory acidosis. Neuromuscular disorders, yes. Guillain-Barré, myasthenia gravis, they're going to affect your diaphragm and your external intercostal muscles. You can't create enough negative pressure. Therefore, you can't get in enough tidal volume. Your CO2 is going to go through the roof. Central nervous system. Well, the central nervous system is what tells the diaphragm to contract. So, if you don't have a central nervous system that is intact, well, you're not breathing well. Okay? It has to be able to signal the diaphragm to contract. Increasing alveolar ventilation, meaning decreasing the CO2. Okay? That's what it means. If your CO2 is high, your alveolar ventilation is poor. So to increase it, we need to decrease it. 3 ways that you can do that, according to the formula. Remember the formula? It says VA equals tidal volume minus dead space times respiratory rate. 3 ways that I can lower my CO2. I can increase my tidal volume, that increases alveolar ventilation. I can decrease my dead space, that increases my alveolar ventilation. I can increase my respiratory rate, that will also increase my alveolar ventilation. Those are 3 ways that you can lower your CO2. But now, which one would you do first? Okay, so if you are given respiratory acidosis, that's an example here. 7.31, 60, 60, and 23. Patient is on tidal volume of 400, respiratory rate of 10. Their dead space is 15. So what I'm going to say is that they are rebreathing CO2. They are rebreathing CO2. I got to stop that. Okay, I'm going to have to somehow remove some of the tube, and I can remove the capnography sensor. I can remove the ballot if that's a problem. I can remove the HME, shorten the whole thing. Okay, so what I'm going to do first now is to remove dead space. So in fixing respiratory acidosis, the very first thing that you do is decrease or remove dead space. That's the very first thing that you do. That's the easiest way to fix respiratory acidosis. You don't even have to mess with the ventilator. See how easy it is? You don't even have to mess with the ventilator. Okay? Now, assuming that the patient, assuming that you don't have any dead space, then the next thing is to increase the tidal volume. Increasing the tidal volume is the best way to fix respiratory acidosis. Removing dead space is the easiest way. Okay? Now, assuming that for some reason you cannot increase your tidal volume because you're already at the 8 mL per kg range, then you increase your respiratory rate. Okay? This other one here, increasing the minimum volume, is a good answer to decrease CO2. Because by the way, to increase your minimum volume, it's either that you're already increasing your tidal volume or your respiratory rate. So you're doing the same thing. Okay? So on the body exam, I'll say, well, here's a blood gas, a respiratory therapist collected. Patient has respiratory acidosis. They're on the ventilator. Which of the following would you do? Well, you start looking for these three here. You look for decreased dead space. Well, there's no option for that. You look for increased tidal volume. Well, no. You look at increased respiratory rate. Well, no. And then you start saying, well, maybe they made a mistake. But now if you look very closely, there is an answer that says increased minimum volume. That's the same thing. That is exactly the same thing. Okay? All right. Now let's say now the patient is on a volume controlled mode. They have respiratory acidosis. How are you going to fix it? Volume control mode is like SIMV-VC or ACVC. Well, the first thing you're going to do is to remove dead space if they have dead space. That's the first thing you do. If they don't have dead space, then you increase tidal volume. But you cannot go over 8 mL per kg, because then that will put the patient at the risk of developing barotrauma. So if for some reason you can't increase the tidal volume just because you're already all the way there, then you increase your respiratory rate, but you cannot go above 20. Here's something I want to teach you. Let me tell you this, the MDRC will take you where no man has been before. I'm telling you the truth. They will take you where no man has been before. Patient is currently, their tidal volume is 300 to 600. Currently, the patient is on tidal volume of 599. And then they have respiratory acidosis. They don't have any dead space, but they're giving you a choice to increase the tidal volume that is in the range. Well, you can go, well, my God, they're only 1 point away, so if I increase it, it's going to go over 600. You don't do that. You still have to increase it. You cannot stop taking a drug just because you think that it may cause a side effect. No, that's not the way we do it. You have to take the drug, then if you have side effect, then you stop it, right? It's similar to this here. So you can assume, well, if I increase the low bit, it goes over 600. No, you increase it, okay? So don't do that. All right, patient is on pressure control mode, and they have respiratory acidosis. What are you going to adjust? Remove or decrease their space, if they have one. Any amount of their space. The next thing is you increase pressure. Remember, on pressure control, we don't set tidal volume, we set pressure, and the pressure generates volume. So we are looking at exhaled tidal volume. Okay? Now, here's my patient here. Let's say that my patient is currently on pressure of 15, and my exact other one is 450. Well, I can increase pressure some more because I still have to go all the way to like 600. Get more pressure. The more pressure, the more volume. The less pressure, the less volume. So you increase pressure. So increasing pressure is like increasing volume on volume control mode. But now how about I increase my pressure to 20, and now the exact other volume is 650. Well, that will not work. You have to decrease your pressure until your exact other volume is within the range of the patient's other volume. Okay? Increase respiratory rate not to exceed 20. Yeah, for some reason, you can increase your pressure because it's going to give you a tidal volume that is over 8 mils per kg. You increase your respiratory rate. Patient is on pressure support. Pressure support is a spontaneous mode. Patient breathes on their own. On the pressure support mode, patient controls their eye time. They control the amount of flow that they get. They control when they exhale out. The only three controls that the therapist will be able to control on pressure support mode is the FiO2, the PEEP, and the pressure level, pressure support level. Okay? Now, I told you how pressure support works. What it does is to reduce airway resistance imposed by the artificial airway. Boom. And hold it there so that the patient can suck in more flow from the ventilator and get more volume. So the more volume that the patient can generate, okay, the more CO2 that they're going to blow off. So they have respiratory acidosis and pressure support. You increase the pressure support level because that decreases airway resistance, making it easier for the patient to get more flow from the ventilator. If they have respiratory alkalosis, you decrease the pressure. That's the only control that you have. Okay? You'll be lucky if they give you pressure support on the exam because that's very easy. Now, this is the formula to use to know where you have to increase your tidal volume or your respiratory rate to get your CO2 to a certain range. So like I told you before, respiratory therapists assume that dead space is constant. They assume that dead space is constant. So when they make changes to fix respiratory acidosis, they really don't think about dead space. It's either like increased tidal volume or increased respiratory rate. Okay? They never do that at the hospital. But the thing though is, if I started with a tidal volume of 400, and now the patient's CO2 is still 60, how do I know what to increase it to bring it down to 40? Okay? Because I can go, well, let me try 500, from 400 to 500. Well, after that, I get a blood gas. Well, it's still high. Then I go, well, let me try 600. And then you stay high. Well, let me try 700. Trial and error is what they do. But if you use this formula here, you can nail it. You can nail on that kind of one exactly what you need to make that CO2 to be what you want it to be. Okay, so what it says here is that desired rate, the rate that you need to set it to blow up the CO2 equals the known rate, which is the current rate, times the known CO2 divided by desired CO2. Okay? The formula works for tidal volume because tidal volume affects ventilation. If I'm doing tidal volume, it will be desired tidal volume equals known tidal volume times known CO2 divided by desired CO2. Respiratory rate affects ventilation, so we already got the respiratory rate. Minute volume affects ventilation. So if I want to know how much minute volume that I'm going to need, it will be desired minute volume equals non-minute volume times non-CO2 divided by desired CO2. If I want to figure out how much alveolar ventilation that I have, normal is 4 to 5, but if I want to figure out what I need, it will be desired alveolar ventilation equals non-alveolar ventilation times non-CO2 divided by desired CO2. It works. So here's example number 1 here. A patient is on the ventilator with a respiratory rate of 8. A recent ABG shows the patient has CO2 of 50. What rate adjustment on the ventilator will normalize the CO2 to 40? Okay, so I'll go here. That is the formula. Okay? Now, the 8 is the current respiratory rate. So I'll put it there, no rate. And then I put down my non-CO2 from the blood gas. And then divided by what I want the CO2 to be, which is 40. So that will give me a rate of 10. So if you go back here, if I increase my respiratory rate on the ventilator to 10, then that will bring my CO2 down to 40. That's what we're saying. In the ICU, if you work in the ICU as a respiratory therapist, sometimes you may have up to 5 ventilators. If you have a patient that is going bad, and you have to do the trial and error, meaning, well, let me try 450, well, let me try 500. You don't have time for that. If you use this formula, I guarantee you will probably just make one change. You know exactly what you need, okay? Yes, number 2. A patient is on the ventilator with a tidal volume of 400. A recent ABG shows the patient has CO2 of 60. What tidal volume adjustment on the ventilator will normalize the CO2 to 40? The same formula, other than I'm going to put the tidal volume where the respiratory rate was. So desired tidal volume equals non-tidal volume times non-CO2 divided by desired CO2. And that's what we got right there. And then it comes out to be 600. So if I go up to 600, from 400 to 600, that will blow up my CO2 down to 40, which is normal ventilation. Number 3, a patient is on the ventilator with a minute volume of 15. A recent ABG shows the patient has a CO2 of 30. What minute volume adjustment on the ventilator will normalize the CO2 to 45? The same formula, other than I plug in minute volume. So we'll go non-minute volume times non-CO2 divided by desired CO2. The answer is 10, so we're going down here. I'm going down to a rate of 10 from, what is the rate here? What was the rate here? One minute. Is that, yeah, that's the minute volume, right? Okay, yeah, so, sorry, we are going down from minute volume of 15 to minute volume of 10. Because the patient has respiratory alkalosis, so you are decreasing your minute volume. Number 4, a patient's alveolar ventilation on the ventilator is 7 liters per minute. Recent ABG shows the patient has PCO2 of 28. What alveolar ventilation is needed to normalize CO2 to 40? The same formula. Desired alveolar ventilation equals non-alveolar ventilation times non-CO2 divided by desired CO2. So work it out, it comes out to be 4.9 liters per minute. If I achieve that amount of alveolar ventilation, then that will normalize my CO2 to 40. Okay? This formula works really good. It works really good. Respiratory alkalosis, causes of respiratory alkalosis, hypoxia with compensatory hyperventilation. So that means that if you don't have enough oxygen, you are breathing very fast. We've already learned that. Oxygen-induced hyperventilation, okay? That will cause respiratory alkalosis. Medication, some medications can cause that. Mechanical ventilation, where the respiratory therapist set a high respiratory rate, that will cause that. Central nervous system disorder, yeah. Have you ever had a patient that no matter what the nurses did to them, they're still gonna breathe 50 times a minute? With sedation and everything, they have had a CNS lesion. Okay? They just breathe, they do whatever they want to do. Okay? Anxiety can cause it. Anxiety can cause it. Pain can cause it. Fever can cause it. Okay? Metabolic problems can cause it. Like when you have metabolic acidosis, you breathe very fast. Well, how do we decrease alveolar ventilation? If the CO2 is less than 35, alveolar ventilation is excessive. We need to decrease that. Okay? Here it is right here. 3 ways again. Decrease tidal volume, increase dead space, decrease respiratory rate. But which one would you do first? So for respiratory alkalosis, I've told you that before. The first thing you do is to troubleshoot any kind of respiratory acidosis, whether it's compensated or partially compensated or uncompensated. Your question is, why is the patient breathing very fast? And then the very first place you look at is your oxygen. Now, if you can rule out anything else that may be causing the patient to breathe fast, then that's when you go to the ventilator and start changing your rate or your tidal volume. But you have to troubleshoot first. So that's what we have there. Look for the cause, okay? Decrease respiratory rate, but do not decrease it to below 10. The only time you can decrease below 10 is when you're winning, okay? And then, if for some reason, you cannot decrease your respiratory rate because you're already at 10, then you decrease your tidal volume, okay? So you gotta know which order to do it. That's very important, okay? Correcting respiratory alkalosis is respiratory in respiratory alkalosis, the patient is ventilating but is overventilating. This means that the CO2 is lower than 35. Ask yourself, why is the patient overventilating? If you find the underlying cause, you fix it fast. If it is hypoxemia, I'll give them oxygen. If it is pain, I'll give them narcotic agent, something for pain. If it is anxiety, I'll give them something for anxiety. Okay? But if I rule everything out, then I decrease my respiratory rate fast. If I can't, then I decrease my tidal volume. Okay, so we went over that with the blood gases. Variables adjusted on the ventilator for respiratory alkalosis. The volume control, okay, well, you identify the cause and try to fix it. If you can't find any cause, then you're going to decrease your respiratory rate. Make sure you're not going below 10. If that is going to happen, you decrease your tidal volume. Okay? But I want to, there's an exception here. Okay? Look at this. So my patient has tidal volume in the range of 600, 300 to 600. That's my blood gas here. The patient currently is on tidal volume of 700. That's above the normal limit. So I'm assuming that I'm giving them way too much volume that's why I'm blowing off a lot of CO2. So in this instance, instead of decreasing your respiratory rate fast, you're going to decrease the tidal volume. Okay, you decrease your tidal volume. That's the only time that you will do the tidal volume fast. Okay? Any questions about that? Pressure control. Treat any identified cause. You troubleshoot first, you're going to decrease your respiratory rate, then you're going to decrease your pressure. Pressure is like volume, okay? When you decrease pressure, you decrease volume. When you increase pressure, you increase volume. Pressure support, you decrease your pressure support level. That will cause the patient not to get huge tidal volume because they're going to have increased airway resistance, okay? And their CO2 will increase. Metabolic acidosis, we don't fix this with the ventilator. Never you breathe for the patient when they have metabolic acidosis. We don't do that. What we do, we give them sodium backup. Okay? Unless the patient goes into respiratory failure because they're getting weak. Causes of metabolic acidosis, ketoacidosis. This is where the body begins to metabolize fat. Now, ketoacidosis, diabetic patients have ketoacidosis. Then when they haven't eaten, they haven't had anything to eat, then their body begins to metabolize fat. So that's one thing I don't like about diabetes. Either way, you are dead. If you eat too much, you're in trouble. If you don't eat enough, you're in trouble. So that's the way it works. You take your insulin, but you haven't eaten. Well, that's trouble. Okay? Okay, so renal failure, loss of bicarbonate, lactic acidosis, that's due to anaerobic metabolism, where your body is metabolizing without adequate oxygen. That will cause metabolic acidosis. I remember I told you that for the babies, anytime a baby has metabolic acidosis, check on their PaO2 first. If their PaO2 is abnormal, you give them oxygen first. Okay? But they do have a lot of lactic acid. Toxin that produces acid. Metabolic alkalosis, we don't fix that with the ventilator. We don't. You give them KCl. Causes of metabolic alkalosis, loss of gastric fluid. You are vomiting. Okay, vomiting, you're losing stomach acid. Acid loss in urine. You're taking diuretic agent like Lasix, Osmitrol, any other kind of diuretic agent will deplete your potassium. So one over that, the other day. Low potassium will cause metabolic alkalosis. High potassium will cause metabolic acidosis. Low bicarb will cause metabolic acidosis. And high bicarb will cause metabolic alkalosis. Excessive bicarb administration, well, you give people sodium bicarb to treat metabolic acidosis. If you give them too much, then you would push them to the other end. Okay? So normally in the ICU, when a patient is given bicarb, the respiratory therapist has to get a blood gas after a while to check and see whether the metabolic acidosis has resolved. If it hasn't, then they will give more bicarb. Vomiting, you're losing stomach acid. Mixed disturbances. This is the only time that you can make two changes at a time. Otherwise, you always make one change at a time. Okay? Intentional iatrogenic hypoventilation. Now, that word there means that you caused it. You intentionally did it. You caused it. That's what iatrogenic means. Well, there are times when we would like for the CO2 to be lower than normal. There are times that we will have to do that. The respiratory therapist will manage that. When the patient has increased ICP, normal ICP is 5 to 10. 20 or less is acceptable. So, if they have ICP, one way that we can reduce the ICP is to constrict the cerebral blood vessel or cerebral artery. That's the vessel that takes blood to the brain. You constrict it so that you have a reduction in blood flow to the brain. Because you see, the brain is a very rigid structure. It doesn't expand with the increase in volume. So you got all this volume going in there, and pressure's going up in there. So that's one way to control it. Another way that we control the ICP, let me go ahead and say that, is by giving them what we call the osmotic diuretic agent, which is mannitol. They call it the osmitol. So to reduce ICP and the ventilator, you are going to lower your CO2. You hyperventilate your patient. You want to maintain your CO2 between 25 to 30. I want you to write that down. 25 to 30 millimeter of mercury. You increase your tidal volume or your respiratory rate to lower the CO2 in that range. Okay? If not, the doctor may decide to give drug, which is mannitol. So the problem with that, though, is if you lower your CO2 to constrict the cerebral blood vessels, then you also, not only would you have reduction in blood flow, you will have reduction in the amount of oxygen going to the brain. The brain needs a lot of oxygen. So in fixing that, fixing the ICP, we want to make sure that the patient's PaO2 is 90. We want to maintain whatever amount of blood that is going to the brain, no matter how small it is, we want to make sure that the PaO2 of that blood is 90. Otherwise, the patient is going to have ischemia, deprivation of oxygen in the brain tissue. Okay? And then we have permissible hypercapnia. Most patients that have very low lung compliance will require very high pressure to ventilate. If you have ARDS, adult respiratory distress syndrome, you're going to require a lot of PIP to ventilate. If you have pulmonary fibrosis, you're going to require a lot of pressure to ventilate. Anything that makes your lungs very stable will require high PIP. Well, the more PIP that you use, the more dangerous it is. The more likelihood for you to develop barotrauma. And you have pneumothorax and subcutaneous emphysema and all of that. So what we're saying then is that instead of continuing to increase pressure, which may result in barotrauma, you can accept a pH that is slightly acidotic, because that's what you're trying to fix. You want to increase your tidal volume or your pressure to blow up more CO2 so that you can normalize your blood gas. But then a patient's lungs may rupture. So we're saying, well, instead of doing that, please accept a CO2 that is slightly high or pH that is slightly low. Patient safety comes first. Patient safety comes first. Okay, so that's what permissible hypercapnia is. Accept a slightly lower pH or high CO2, that way you want to say, instead of continuing to use high pressures that will cause barotrauma. Okay? The normal pH is, for that, is anytime the pH is greater than 7.2. if I'm ventilating a patient that has ARDS, and my pressures are going high now, and my pH is greater than 7.2, I can say, well, instead of me trying to increase it some more to blow out more CO2, I'll just have to accept a pH that is 7.5, 7.25, 7.21. Okay, that would be good. Okay, or maybe CO2 that is slightly above 50. You may give sodium bicarb to increase the pH. This here is called HODS-NET. HODS-NET, protective lung strategy. When you're ventilating somebody with ARDS, you only use a tidal volume that is 4 to 6 mL per kg. Because you want to give them very small tidal volume so that the PRP will not go up. You make up your ventilation by increasing the respiratory rate. So if I lower my tidal volume, I increase my respiratory rate to control my CO2. That's what ordinance means. It also means that you can give sodium bicarb to increase their pH. Now, if you get a PaO2 that is between 80 to 88, that should be fine. Any questions? That's it.